Hi, I'm Monte Eaves from Emory University, Atlanta, and with me is my colleague Achilles Thoma from McMaster University in Hamilton, Canada. In this edition of the EBM Hub, we will be discussing an article by Flugstad and colleagues examining their experience with the Keller funnel. The authors claim that the Keller funnel reduced the incidence of capsular contracture by more than 50%. We hope that you have already read the article and performed your own critical analysis, so we can see if we're all thinking along the same lines. For those of you who are not aware of, or if you haven't used a Keller funnel, it is a very simple device, and much like a pastry or piping bag used in cake decoration. The purpose of the funnel is to allow an implant to be gently placed into the breast pocket without touching the skin. To use, first we're going to remove the inner lining, and then the end of the device is trimmed to the appropriate size so that the implant will pass. The implant is then placed into the large end of the funnel, and then the narrow end is inserted through the incision and into the pocket. Once positioned, just squeezing the bag will advance the implant out the end and into the pocket. The theory is that by preventing implant contact with the skin, the risk of bacterial contamination, which could lead to capsular contracture, is reduced.
Hi Monty, it's Achilles here. In regards to this article, tell me what your understanding is of what these authors did.
Achilles, the authors examined the incidence of capsular contracture in two groups of patients undergoing breast augmentation in several different practices during the two time periods. The first group included patients who underwent augmentation before the funnel was introduced, and the second group included patients in whom the Keller funnel was used. For each group, they calculated the number of capsular contractures at 12 months after surgery that led to repeat operation for that specific indication. Based on this information, they concluded the use of the Keller funnel reduced the incidence of capsular contracture by 54%.
Monty, this seems like an astounding risk reduction for a new innovation in aesthetic surgery. If this is true, it will have a huge impact in augmentation mammoplasty.
I totally agree. But Achilles, how do we find out if this is really true?
Whenever you're ready.
My approach is to be cautious. When it comes to new technologies, I perform a critical appraisal of the article first. In such an appraisal, I examine the methods used in the study. I look for methodological flaws which can introduce bias, which may distort the results and the conclusions. For this particular article, I can think of a number of questions you can ask. For example, how might the method of selection of the practice groups involved affect the result? So Monty, when you read the article, what did you think about the method of practice group selection?
To me, it appears that the practices that were already favorable to the device were suggested or selected by the company, and practices that had tried but had stopped using the device were not suggested. So I see here a selection bias. In addition, I see a potential risk of bias in the selection of the patients in the two groups. Achilles, do you think the patients were similar in these two groups?
It is possible that the two patient populations were different. The Keller funnel patients may have been of higher socioeconomic class and they could afford the extra cost of the funnel. We know that higher socioeconomic groups in general are healthier and hence less likely to have complications. So the only way we have to ensure that the patient populations are similar is to randomize them. In the study design used in this article, however, this was not possible. So Monty, the authors mentioned that they sent out a survey to ask the surgeons if they had changed their practice pattern during the study period. What do you make of this?
That is exactly right, Achilles. The authors used the survey to assess whether other practice changes, besides the use of the funnel, may have contributed to a change in capsular contracture rates. That is certainly important information I'd like to know. However, the survey asked about factors that occurred years before, introducing recall bias into the practice selection process. it would be improbable for a surgeon to know whether or not he or she somewhat altered their patient mix, incision location, pocket location, implant texture, size, brand, implant type such as saline versus silicone, perioperative protocols, or any other number of factors without actually collecting the data. Practices evolve, so it's likely their techniques change and improved over time with increased experience. Another concern is that 2 practices were excluded from the final analysis. But what if their results were worse? The authors also mentioned that the number of patients lost to follow-up is unknown. Achilles, by what mechanisms might differences in follow-up occur and alter results?
If there was a differential loss to follow-up in one group than the other, this would alter the results. If, for example, more patients in the final group were lost to follow-up and more of these had capsular contracture, this would lower the recorded incidence of contracture in this group simply because the authors never had the opportunity to assess them. Monte, another issue that needs to be considered is this thing about the conflict of interest. Does this bother you in this study?
Achilles, conflict of interest is certainly a concern. Studies have consistently shown that conflicts of interest, especially when a company is funding the research, as in this case, make it much more likely that favorable results will be reported. Conflict of interest could have affected the results of this study by several potential mechanisms. For example, these would include bias in the nurses collecting data as they were paid by the company, bias in the biostatistician who was also paid, bias in the doctors who had their salary deferral for their staff, communications between the study sites by company, editing by company officials, selection of the surgeons to include in the study, and input into the decision to exclude 2 of the 9 study sites. So for me, conflict of interest is a major consideration in assessing this article. So Achilles, in light of your critical analysis, what do you think of the author's self-assessment of their current and potential future study methods and conclusions?
To their credit, the authors admit to multiple potential sources of bias, including the conflict of interest, the need to compare groups directly based on specific data, and the value of more traditional randomized controlled trial. They acknowledge that more information is needed to make sure that the treatment groups are similar. Unfortunately, their approach is to bootstrap the evidence through another study using longer follow-up time and collecting more surgical data such as pocket placement, incision placement, implant size, and implant time. This approach will not bring us closer to the truth, however. The only way we can accomplish this is through a properly executed randomized controlled trial in which the industry sponsor takes a hands-off approach and allows the investigators freedom to execute the study and report the findings, whatever they may be, positive or negative. So Monte, based on your critical assessment of the evidence presented by the authors so far, are you convinced there is enough evidence to change your practice now in order to reduce capsular contracture by using the funnel?
Based on the evidence presented in our critical appraisal, I remain unconvinced that the Keller funnel reduces capsular contracture. It certainly could be true, but the evidence presented and the methods chosen are not convincing that it has been proven at this point. We challenge the authors of this article and other investigators who want to study the impact of the funnel on capsular contracture to produce level 1 or level 2 evidence to support or refute this claim. Achilles, thanks for a great discussion, and thanks to all of you who are out there and who are performing your own critical analyses. We look forward to having you back for our next Aesthetic Surgery Journal EBM Hub edition.